As of February 2017, UHG are introducing a new lilac coloured drug chart. We're accentuating the importance of documenting heights and weights for many drugs, as well as recognising that the laboratory values for GFR are based on average patient size. We also remind all users of the drug chart that a null allergy box is unacceptable, so if a patient does not have any allergies, it may be documented as such here. We have instituted a maximum 400 milligram gentamicin dose that is in accordance with institutional guidelines, and only on advice of micro or ID would that dose be exceeded. We remind users that gentamicin doses can be calculated using the GAP app, and that loading of vancomycin should be considered for certain patients. On page 5, our intravenous medicines can be prescribed, pages 5 and 6, and there are 6 dosage slots. On the very rare occasion that other routes may be required for intensive medication, such as 4-hourly, you may also use this part of the drug chart. On page 7, thromboprophylaxis guidelines allow the prescriber to tailor therapy toward a certain platelet count if 75 is not the desired cut-off point for administration of low molecular weight heparin. We also provide some guidance on dosing in obesity or underweight patients and those with renal impairment. Page 8 is where VTE prophylaxis is prescribed if warranted, and we also ask doctors to complete the checklist to ensure that a full medication history is conducted with the patient. Their own medication can be a very good prop for prescribers who want to verify medicines, and we remind prescribers that there are more than tablets that are medicines, as patients tend to focus on these and neglect all the other examples of medication that they may be using. As far as the emergency department goes, prescriptions may be written on the pro forma prior to a patient's admission, which means nothing appears on the drug chart alluding to recently administered medication. So the doctor should indicate this when starting a drug chart. A nurse may also flag drugs administered at an AME. On page 9 we have our dosage codes, and we might remind prescribers and nurses that 999 on a drug chart is written by a pharmacist where they consider to carry out the instructions on the prescription would be dangerous. It's very rare, but it is necessary, and in that case a registrar or a consultant should review the chart urgently. On page 13 we have a 6-point safety checklist for warfarin. Most importantly, when charting warfarin, please review all drugs affecting hemostasis, in particular antiplatelets, and indicate whether they are to be stopped or continued indefinitely, or continued for X number of days, for example. On many pages of the drug chart we have some info bulletins at the top. This one concerns maximum dosing of IV paracetamol, which should be weight-based when a patient is under 50 kilograms. On the next page we discuss the use of anti-inflammatories in patients with cardiovascular risk factors. On midway down page 19 we provide some guidance as to the appropriate use of warfarin and antiplatelets together, when that may be appropriate and when it may not be appropriate, thanks to Dr. Gilmore's contribution. Again, heavy involvement of Dr. Gilmore in the construction of anticoagulation guidelines. There are 3 important safety steps: reviewing all drugs affecting hemostasis when charting an anticoagulant, reviewing them for interaction potential, and arranging community supply. Anticoagulant choice, for example in pregnancy, cancer, antiphospholipid syndrome and more. the importance of considering renal impairment with all low molecular weight heparins and DOACs, maximum doses of enoxaparin in severe renal impairment, maximum therapeutic dosing in acute coronary syndromes, and the necessity to avoid prolonged or even BD dosing in patients who solely have non-valvular atrial fibrillation. Page 21, we provide dosage guidelines for the factor Xa inhibitors and note that renal impairment is an important consideration. And then for the treatment of venous thromboembolism as well, doses are very different and there are loading doses for many of the DOACs. So read this with caution. There is also a generic drug interaction table for pharmacokinetic drug interactions, not synergistic ones, and we highlight it is important to consider that they may vary with DOAC, so check up to date and the manufacturer's SPC. On page 22 there are visual guidelines for prescribers new to the hospital or transitioning from med school as to the best way to stop a drug, document a null allergy, as a blank allergy status is unacceptable, precautions to take with insulin and warfarin, for example, and how to chart reducing dose steroids. And if you want to share this video with others, just remind them that it can be accessed on YouTube via MedInfo, our intranet address. Thank you.